the 22nd Bangkok International Symposium on HIV medicine. I'm Pachari Raksa Wong, and we will be going straight into the live interview sessions here. I have with me, and lovely to have you here, Dr. Eugene Kroon from the Thai Red Cross AIDS Research Center. Sawadee ka. Good morning to you.
Happy to be back.
It's lovely to have you back, and we hope that you will continue to join us here because you've always been a great help. You're going to be extracting more highlights from what's been presented inside the main conference room. So we'll start with the first topic, which is broadly neutralizing antibodies, and we have with us our first guest for the day, Dr. Denise Hsu. She is with the Armed Forces Research Institute of Medical Sciences of the US Military HIV Research Program, Walter Reed Army Institute of Research, Thailand. Sawadee ka.
Sawadee ka. Sawadee ka.
Thanks so much for joining us. And I'm sure everybody appreciated your presentation earlier on today.
Thank you.
Dr. Denise, yes, we did, because it was a very comprehensive talk about broadly neutralizing antibodies. For the audience who are not familiar with broadly neutralizing antibodies, can you tell us a little bit about the concept in general? And then, since we have antiretroviral therapy for treatment and prevention, why are we pursuing broadly neutralizing antibodies?
So, broadly neutralizing antibodies are antibodies that target the HIV envelope. And they actually develop in patients with chronic HIV infection. So they develop naturally, except most of the antibodies that are found in patients are not very effective. But in very small number of patients, they have these very special antibodies that manage to neutralize or block HIV entry that can be matched to many different strains, so that are active against many different strains. And these antibodies have been isolated from a very small subset of patients, and they are actually now being applied in a clinical setting. In terms of what you mentioned about their use in prevention as well as treatment, so I will address the question of prevention first. So in HIV prevention, there are a number of good strategies already. There's PrEP, which is extremely effective, but I think certainly most of the interventions thus far requires a lot of adherence, or the users have to take certain medication or use contraceptive barrier methods regularly, or they can't really stop, or if they stop, the efficacy will be lost. So it takes a lot of dedication and even pre-planning. Whereas for broadly neutralizing antibody, at the moment we're still very early on in the development, so when we administer, we also have to administer it regularly at the intervals of 8 weekly. But the hope is that once we prove the concept of effectiveness, we can actually make the administration much less frequent. So participants or volunteers or individuals do not have to use something every day. It could be administered every few months or even 6 months, or eventually maybe we can engineer it and then inject it into what we call viral factors, which will stay in the participant's body and continue to produce the antibiotics and provide this long-term coverage that the individuals will not have to remember to do something and yet still have the protection. So that is for the prevention side. For the treatment side, as I mentioned in my talk, with antiretroviral therapy, we of course have a very good viral control. However, once we stop therapy, the virus bounces back. And that is because there are parts of the virus that we cannot get to with antiretroviral therapy, what we call latent reservoir, or they're like dormant viruses. And there are signals showing that the broadly neutralizing antibodies can target these factions that antiretrovirals cannot. So that's why there's a lot of excitement regarding this as well for treatment and remission.
Then the next follow-up question, based on you speaking more or less about long-acting monoclonal antibodies, if we compare that to long-acting ART that's under development, what would the benefit of an antibody be in that context? Would there, for example, be less expected side effects? And secondly, what are barriers still to be overcome to get the broadly neutralizing antibodies to where you want them to be?
I think in comparison with long-acting ART, I think different therapies will have different side effects profiles. So even though the broadly neutralizing antibodies have been very safe in clinical study, it still has only been tried in a small number of patients, whereas we have a lot more experience with antiretroviral therapy. So there may be potential adverse effects that we're not aware of yet in terms of long administrations. And then your second question, sorry, Dr.
What
Ije.
would still need to be overcome? And in particular, I was thinking in your talk, you stressed that there is quite a bit of volunteers who may have lack of sensitivity to certain antibodies even before starting, which is unique for ART. In ART, that only happens if people get infected with a virus from a highly exposed individual. How does that affect the development, and how does that happen?
So I think the pre-existence resistance will be less of an issue in terms of prevention because in prevention the participants are not yet infected and the antibodies are on board when they first get infected. And of course at the time of infection the virus is, there's a single founder virus. So that will not be an important issue in prevention, but definitely in treatment the pre-existing resistance of the virus is important. And this is in contrast to ART because in antiretroviral therapy, the participants start antiretroviral therapy, they have never been exposed, theoretically. Whereas before the participants get administered the broadly neutralizing antibody, their virus has already been exposed to different antibodies that their body is trying to reproduce. So their virus has already been trying to escape for years from their own immune responses. And so then there may be small populations that are resistant to other broadly neutralizing antibodies as well. And that's why there's more of an issue with pre-existing resistance.
Makes perfect sense.
Thank you so much. That was very interesting and very informative, and we appreciate that. Putting into perspective for us, what are broadly neutralizing antibodies, and also touching on prevention and treatment. We thank you for being here with us, Dr. Denise Hsu. Thank you.
Thank you.
We're now going to move on to the next topic, the art of initiating antiretroviral therapy, and we're going to be joined by Dr. Iskandar Azwa, who is with the Infectious Diseases Department at the Faculty of Medicine, University of Malaya in Malaysia. Sawadee ka, selamat pagi, warm welcome.
Very good, thank you. And you?
Very good too. We're all doing very good and very happy to hear the latest developments and updates.
Fantastic.
Right, and we're going to start with your session here on initiating ART.
Indeed. Dr. Iskandar, you made a very strong case just now in your presentation for same-day ART.
I'm glad you thought so.
Yeah, no, I think it's a very good case. And I just would like you to reiterate here for people at home watching why you think we should be moving towards same-day ART, and then if there are cons or perceived cons, what are they, and what would be your answer to them?
Okay, so I'll start with the benefits. If you looked at, so the initial part of my presentation involved a couple of slides around treatment cascades of 4 different countries across the region. So we had Thailand, Malaysia, and Vietnam. So in terms of the UNAIDS targets, the 1990 targets, certain countries like Thailand, Malaysia do quite well in terms of, or relatively well in terms of testing. Malaysia in particular, when it comes to the second target, does atrociously.
What is the second target?
The second target where they're initiated on ART, on antiretroviral therapy. And so, and maintain on antiretroviral therapy, they do particularly bad. And so there are huge obstacles which need to be looked into further as to why, after the point of diagnosis, patients are not initiated on antiretroviral therapy. Now, you could come up with a couple of reasons, and some of those reasons are essentially doctors insisting on waiting for blood tests. So you know, you're referred to a treatment center, you get a confirmatory blood test, that takes some time. And then you get the first visit bloods.
Yes.
And then you get the multiple preparatory visits for antiretroviral counseling.
Yes.
So you coupled into all that, it's no wonder that by the time the patient is ready or perceived to be ready to initiate antiretroviral therapy, they've already disengaged in care. So it's really a doctor structural barrier, which is really causing patients to disengage from care, even well before they initiate antiretroviral therapy. But your question, coming back to the benefits, so the benefits of same-day antiretroviral therapy essentially is that what we have shown, or what certainly the Thai Red Cross AIDS Research Centre have shown, is that even with regimens such as TDF, FTC, and efavirenz, they're able to keep patients in care. Their viral suppression and retention in care at 12 months are excellent.
Wonderful. Very good.
Thank you.
So if we then are moving to same-day ART, the next point you made in your presentation was that according to the latest guidelines, we should be moving to integrase-based regimens. You had some footnotes there. So do you agree that we should be moving towards integrase-based regimens, and what are any drawbacks of such a move?
So WHO have made their recommendation since 2018.
Okay.
There was that concern around the safety signal of dolutegravir in women of childbearing potential, but with the follow-up of the Symposium cohort, and that reduced essentially the prevalence to less than what was initially thought, to 0.3%, still higher than women who conceived on non-dolutegravir regimens, but much lower than what was anticipated. I mean, integrase inhibitors, they are very tolerable regimens. They're given once daily. Dolutegravir in particular has a high genetic barrier to resistance, very few drug-drug interactions, and why not is the question, rather than what would be the concern. So, of course, there are real-world life data emerging with dolutegravir, and I also showed that in my presentation. The concern around weight gain in particular and its association with metabolic disorders, as yet, which has not been shown, but the concern around weight gain in females, particularly black females, is of concern. But still, if you ask those women who were initiated on dolutegravir, would they prefer to stay on dolutegravir despite the weight gain or go to efavirenz, they still would choose dolutegravir.
So that would lead to an interesting question then. As providers, if you would have to choose your own regimen, would you choose an integrase?
I still would. I still think this is, I mean, HIV treatment tends to gets released very quickly after, it tends to get licensed very quickly after generally 48 or 96 weeks. And that's important to maintain. What is important is that any safety signal that emerges as patients continue are reported from real-world life data. So as long as we have that, that is okay.
Yes.
Right? So I think that's important to follow up. It's certainly a signal. It's a signal that we're slightly concerned about, but I still think compared to efavirenz, dolutegravir are the preferred regimens for treatment-naive patients.
Wonderful.
Hands down.
Okay.
So.
Thank you for your
Thank you
time.
very much.
Thank you so much. Now, if you did miss Dr. Azwa's presentation, you can watch it again. All presentations are made available again online. All you have to do is go to HIV-NAT's website. Thank you so much to you, Dr. Iskandar Azwa from the University of Malaya, Malaysia, at the Infectious Diseases Department, Faculty of Medicine. The last topic of discussion for our first session, the live interviews as part of the 22nd Bangkok International Symposium on HIV medicine. We focus on the art of managing HIV resistance. We are going to be bringing back a guest who joined us yesterday, Dr. Daniel Kuritzkes, Professor of Medicine at Harvard Medical School, Chief of the Division of Infectious Diseases at Brigham and Women's Hospital in the USA. Sawadee ka. Sawadee ka. Welcome back. He's perfected the Y. Andy Sawadikab.
Dr. Kuritzkes, thank you very much for a comprehensive talk, very interesting. For the people watching who are not here today, would you mind summarizing why drug resistance is an issue in HIV infection?
Drug resistance is important because if you don't fully suppress the virus, the mistakes that the virus makes each time it reproduces itself will introduce mutations that lead to resistance to the drugs that we're using to treat the patient. And so the more resistance that there is, the harder it is to achieve full suppression, the greater the likelihood that patients will have disease progression.
Okay, so then, I remember the old days with relatively few drugs, but now that we have more than 30 drugs available, there's still a lot of concern about drug resistance. Why is that? If we have such a big arsenal of drugs, why do we remain concerned?
The problem is that if once resistance has occurred, it tends to accumulate, making each successive line of therapy less and less effective. Now, it's not as much of a problem for people starting treatment anew today, using the newer drugs for the first time. They're much more likely to achieve full suppression and to avoid resistance altogether. The big concern is people who have been on therapy for some time with perhaps only occasional monitoring of their virus loads, which is the case in many lower and middle income countries, where you may not know that somebody's having virologic failure, and they continue on their drug. That allows the accumulation of mutations. Then you switch them to a new drug regimen without the advantage of resistance testing, and may just compound the problem.
Okay, so then we have the problem. How do we treat it? Like if I have a patient who has become resistant to multiple classes of ART, what do I do?
The best approach is to use 3 completely different drugs that are not cross-resistant to the drugs the person might already have failed. That's most easily done when we can test for drug resistance by genotyping or other approaches. But even if you can't do the testing, we can predict reasonably well which drugs are going to still be effective in the setting of resistance and which will not, and to try and focus second and later lines of therapy on the use of those drugs as is recommended by the WHO guidelines.
Wonderful. So then, now I have a patient in my clinic who has been treated since 1994 and is truly resistant to all existing ART, to all classes, has issues. In your presentation, you mentioned some new and upcoming options for such volunteers or patients. What are they?
Well, we're fortunate that drug development is continuing and new classes are being discovered. And so there are 2 new types of drugs known as entry inhibitors, one of which is an antibody, not directed against the virus, but directed against the viral receptor, CD4. And that drug, ipilimumab, was recently approved by the U.S. Food and Drug Administration for use in exactly this setting. A second drug called fostemsavir actually binds to the virus envelope and prevents the virus from attaching to the cell, and is completed phase 3 clinical trials and is now pending approval.
So that's also an entry inhibitor?
Also an entry inhibitor.
Terrific. Then last question I have is PrEP. We've heard a lot about PrEP, both at this meeting and other meetings. Do you perceive PrEP as a potential hazard for drug resistance development?
The issue of drug resistance and PrEP is a really challenging one. To date, we've been very fortunate that there's been very little resistance with the use of PrEP. It's almost always occurred in the context where somebody has started PrEP not realizing that they're already infected, in which case they're essentially getting inadequate 2-drug therapy. People who have failed on PrEP and become infected have almost always done so because they're not taking their drug, and so they don't get drug resistance. There is concern, though, especially as PrEP is used more widely in lower income countries where there may be pre-existing resistance to some of the components of the PrEP regimen, and only time will tell whether that's a real concern or not.
So we need really good surveillance.
We need very good surveillance, absolutely.
That's really all the questions I have for you. Any questions on your part?
Pardon?
Any questions on your part?
I'm good because he has a very busy day. He's got something coming up in about 3 minutes, so we are going to let you go. But thank you. It was great to hear about the 2 new drugs. Thank you once again for coming in to share with us your experience and your expertise. Dr. Daniel Kuritzkes, he's here from he's the chief of the Division of Infectious Diseases at Brigham and Women's Hospital in the USA. Now, your next plenary session, you'll be giving us an update of HIV genotypic resistance testing. I'm sure they're very eager to find out more. Thank you. Thank you so much to you. And that is going to wrap up the first live interview session. Last day now, don't miss out. Continue to watch us live as we'll take you back inside the main conference room to find out more about what's being discussed in there. And then join us once again for more live sessions later on. I'm Pachari Raksa Wong and Dr. Eugene Kroon. Sawadee ka.
Sawadee ka.